Hi, Erica. Sorry, I'm a little bit late, so I'm meeting. The connection wasn't working on my side.
No problem.
Is that you, Prof. C? Hi, Jackie.
Hello,
I just turn my camera on. Oh, it's not working. How are you doing?
is it Nicole?
Yes, Nicola here.
There's Erica as well.
Perfect. Do you want to practice? I mean, I'm sure you've used Zoom many times, but if you want to practice sharing your slides.
That'll be
Hello,
good.
hello. Can I ask a question?
Yes, sure.
So, am I gonna get the Learning Cafe present certificate after sending?
Sorry, say again for me.
Am I gonna get the Learning Cafe present certificate?
I'm struggling to hear you. Can I ask if you could put the question in the chat for me?
Okay, okay.
Thanks.
Thanks, Nicole. Can you see my wait, I think I've
Yes.
got it wrong. Let me just try once more, sorry. Slideshow. Okay, wait, it's giving me not the right format here. Sorry, I'm just gonna try and share another screen. I don't think I did it correctly.
No problem.
Not giving me my own notes. Sorry, Erica, would you like to try first?
Okay, let me try quickly.
It's looking good. I can see presenter view.
No, we can see your note.
Swap it.
There we go.
Okay. Perfect. Just try again, Jackie.
Okay. So did you share the PowerPoint screen or just the entire screen?
No, I shared the PowerPoint. Do you
Okay,
have two
then
screens?
no, I disconnected the one now.
Okay.
And then to get to my presenter view,
Oh, so I did it with two screens, Jackie, sorry.
okay, let me just quickly try this. Oh, it wasn't doing this earlier. Classic.
Yeah, it's always when you need to work this.
Yeah, hey. It's just not giving me this presenter mode now. Let me just see here quickly. Oh, there. No, it's not giving me presenter.
And the swap screen option that Erica used, is that?
Was that on Zoom?
Yeah. Go to display settings, and then you say swap presenter view from slideshow.
Under more.
So if you go into just presenter view, there's something that says display settings at the top. It's not a Zoom thing. It's a PowerPoint.
Oh, yeah,
thing.
yeah. Okay, sorry, just say that again.
So you go into presentation view, and then there's top left, it says show taskbar, and then it says display settings. Go to display settings, press the drop down arrow, and then
Are
say,
you seeing that on my screen at the moment?
oh, sorry, I was looking at mine. Hold on, let me look at what you're looking at. No. Well, so you're in presenter view now, right?
But it doesn't give me my own screen, so it's not showing me the black on the sides.
Let me walk to you quickly.
We've still got some time, hey, Nicole, is that okay?
Yes, we do. No stress.
Okay, thanks. Sorry, I'm going to figure this out now.
To where?
Hey, Jacques, it's Tinus. Do
Yes,
you
Tina.
want to? Hi there. Are you sharing your Zoom? Are you sharing your Zoom window, or are you sharing your PowerPoint? What did you do? What did you share?
PowerPoint.
But
That's fine.
Jackie,
Laptop.
aren't you supposed to do that after me? Am I not supposed to be the first one?
Yes, Prof. So we were just practicing. We're just testing if we showing the correct screens.
Okay. All
Okay.
right then.
Do you want to put two screens on? Sorry.
It's okay because
Prof. C, are you comfortable sharing the introductory slides? Would you like to test it? Or are you good to go?
It should be straightforward, isn't it? I don't have to go through all the slides. I will
No.
talk through the key points. What would you say are the key points?
The housekeeping notes are pretty standard there for all the sessions. I would just make a note that people need to attend for 60 minutes to get a CPD point. And then after that, it just has the speakers' bios that you can run through, and that's it.
All right. And after that, you just introduce the speakers, right?
Yeah, so the bios are on the screen, the
Yeah, I
last
saw
few
them. I saw them.
Yeah,
I've
yeah.
seen them. I've
So you
seen
just
them.
introduce them, and then you say next week's topic is porphyria, and then you hand over to Erica.
Next week's topic is porphyria. Who's presenting?
It's the very last introductory slide.
Say?
It's the very last introductory slide. It's
Oh,
Dr.
okay. Okay. No, I
Bizarre
got you.
and yeah, there we go.
Where's Ramia? Is this KZN? Where's
Yeah.
Bizarre? Wits.
It's Bizarri.
Yes, it is.
It's Bizarri and Ramia from KZN.
Yes, good
Okay.
afternoon, Prof. Chapanduka. Hi, Ziv. It's
Great
Estelle
to
here.
hear you.
Hi, it's
How are
great to
you?
have you. It's going to be
Thank you.
amazing. Yes, we well, and I trust you also very well.
I am, thanks. And I
That's great.
am ready
when you are. It's 4 o'clock, so we just wait for how many people?
There's 60 people, so I think it's a good time to. You're welcome to start if you'd like to.
I can start now?
Yes, you can.
Let's give it a minute. I think it's 1600 on the dot with 65 people. Okay. Let me put in presenter mode. I don't know why I really wanted this slide. Yes, good afternoon, everyone, and thanks for joining Deep Dive today. Special thanks to the Deep Dive team for putting this together for us week in and week out. We really appreciate it. And while I'm at this point of the presentations, let me just go through some housekeeping notes. Please note that ideally you should attend all 60 minutes in order to get credit. That is CPD points. I'm sure you know how this works. There is an announcement there which relates to the upcoming hematology oncology conference in September here in Cape Town. We look forward to seeing you then. Now, I want to just introduce the two speakers today, Dr. Jackie Russ and Dr. Erica Nell. Both of them are with us here at Tygerberg Hospital. Jackie is a registrar in the department, and she's been with us for some time now. She's well on schedule to complete a training next year, all things being equal. She got her first degree, the MBCHB from Vrystaat, where she developed a strong interest in hematology. Now, we all know that testing of the antiphospholipid syndrome is quite complex. And it's that complexity which inspired Jackie to delve deeper. And the point is made there that Jackie is a keen runner. This young lady has done a very healthy comrades. I don't want to mention a time in case she's telling her friends that she did better than she actually did. But honestly, it's a time which some of us only dream of. So she's quite a keen cyclist, and she runs up mountains. And let me just complete by introducing the next speaker after Jackie, and that's Erica, who's been with us since since before she qualified. She trained here with us. She came in with an MBCHB from WITS, but before that, she already had a master's from UCT. And it's during that master's that she developed an interest in genetics. And she had a fellowship obtained here. I'm glad to say that she got the Coulter Medal. I think she doesn't want me to mention that over and over again, but I also take pride in that. And of course, she had a degree cum laude from here. She's involved in various aspects of lab diagnostics and research. She's a very keen teacher of registrars. She's got a keen interest in statistics and can stand in for a biostatistician. And she is in charge of one of our undergraduate student programs. Now, having said that, I would then like to hand over to the speakers. I don't think there's anything I left. Organizers, if I forgot something, please help me. Otherwise, I'm going to stop sharing now and give the floor to Jackie Russ.
Thank you for the introduction, Prof. If I can just confirm you can see my slides correctly, and then I'll start.
Yes, we can.
Okay. So good afternoon, everybody. Today, firstly, I'd just like to thank Blood SA for this platform where we can all learn from each other. And as one of the presenters today, I'm well aware that there's a lot of experience in the room. So please do feel free to comment and contribute. And I'm going to start off with, let's see if it goes on. I'm going to start off with an short introduction into antiphospholipid syndrome. Just want to get my pointer. There we go. Okay. So antiphospholipid syndrome is a systemic autoimmune condition, and this is due to the persistent presence of autoantibodies. So we can see here our B cells produce antiphospholipid antibodies, and these antibodies are then directed either towards phospholipids or proteins which are bound to the phospholipids, in this case beta-2 glycoprotein 1. And these phospholipids are found on the surfaces of platelets, endothelial cells, as well as neutrophils and monocytes. And while the pathophysiology is quite complex, in summary, we get upregulation of tissue factor, suppression of tissue factor pathway inhibitor, downregulation of some of our inhibitory pathways, and increased complement activation, resulting in thrombosis as well as pregnancy morbidity. So onto the antiphospholipid syndrome diagnosis. So it's important that there's a laboratory as well as a clinical component. So firstly, with regards to the laboratory component, we can see here that there's two separate tubes. And this blue top tube is a citrated tube, which comes to hematology. And we have a yellow top tube, a serum separating tube, which goes to immunology. Now, starting off with the hematological tests, Eric is going to go into much more detail about this, but in basics, we perform two tests, a dilute Russell Viper venom test and a lupus-sensitive APTT. And as a result of these phospholipid antibodies, which bind to the phospholipid surface, they interfere with the formation of certain complexes that are necessary in the production of thrombin. And as a result, these coagulation tests are then prolonged. And two are necessary in order to identify all the lupus anticoagulants, and that is our hematological test. On the other hand, we have our immunology test. Now, this is a test performed for anticardiolipin antibodies and anti-beta-2 glycoprotein 1 antibodies, IgM or IgG, for both of them. And as we can see, this is a solid phase assay, and it detects the antibodies. Now, according to the ISTH 2025 guidelines, it's important to perform all three of these antibodies, and ideally on the same episode. This is important because it helps us to determine a patient's antiphospholipid antibody profile, whether a patient is single positive, double positive, or triple positive, depending on how many of the three you have. And this is shown to be clinically relevant, as if you have a triple positive profile, it is shown to have an association with thrombosis and pregnancy morbidity. And what is important as part of this criteria, in order to show persistence, one needs to have a positive result 12 weeks apart. And then the other element is the clinical component, which we'll go into a bit more detail, and this varies slightly based on which criteria one is using. So I'm going to start us off with a case. And this case is of a 42-year-old female. She's got hypertension and she's a smoker. And she presented with a DVT in her right leg. So if we have a look at her results, and these are actually how our laboratory reports them. I've just actually screen grabbed them and put them together. And I've done that so that we can just look how it's reported and how what we queried is how it would be interpreted. So we can see here, these are anticardiolipin antibody tests, the ELISA-based tests, and we are performing IgG. Our laboratory only performs IgG, but we'll delve into that a bit later. And we can see that we have a positive or a negative result as well as a value, and GPL is the unit because it's IgG. And what we can see here, So firstly, these two tests over here are about 6 months apart. Then we've got one that's 3 years apart, and this one is about, again, 6 months apart. And we can see a positive result of 42, then negative of 10, positive of 31, and positive of 47. Now, based on the fact that this patient has got the clinical element of thrombosis, as well as some positives here and potentially 2 positives here, would you say this patient has antiphospholipid syndrome? So not going to do a poll, but think for yourself. And as we go through the criteria, we'll come back to this case. So just to touch up on the detail of the criteria, firstly, we'll look at the revised 2006 supplier criteria. And this criteria requires 1 clinical element and 1 laboratory criteria. And what we can see here is 2 major ones is vascular thrombosis, where you require a thrombotic episode of either arterial, venous, or small vessel thrombosis. With regards to the pregnancy morbidity, and apologies for the busy slide, but it's just there is a lot of detail within this. If we look at A and C together, we firstly can use the 10-week gestation, and this is 1 or more unexplained death of a morphologically normal fetus beyond 10 weeks, and C is 3 or more unexplained consecutive spontaneous abortions before 10 weeks. And then B is a premature birth as a result of eclampsia or severe preeclampsia or features of placental insufficiency. And then onto our laboratory criteria. As I mentioned, there's 3 different antibodies that we are testing for, and one requires 1 of these, whether it be IgG and or IgM. They need to be at least 12 weeks apart. And important here is the detail where they give a value for anticardiolipin of more than 40 GPL or MPL based on IgG or IgM, or the 99th percentile. And anti-beta 2 glycoprotein 1, they only mention greater than the 99th percentile. Then they have released a newer criteria, the ACR-EULA criteria, and this was released in 2023. And this is a similar approach with regards to clinical features and laboratory features. However, they've slightly changed it by adding different domains. And we can see here we've got 6 clinical domains. The first 3 domains are also have got to do with thrombosis. Domain 4 has got to do with obstetrics. And they've added this, which is unique to this criteria, is the cardiac valve as well as a hematology component, which includes thrombocytopenia. And then at the bottom, we've got domain 7 and 8, which are laboratory components. Okay, so I just want to touch on 1 or 2 details here, the underlying parts. We can see that they've added a weighted system here. So one needs 3 points from the clinical criteria and 3 points from the laboratory criteria in order to meet antiphospholipid syndrome diagnosis. So we can see here, due to the point system that they've allocated, with regards to the thrombosis, when you have risk factors, here it says with risk factors, then one gets lower points. Okay, and then with regards to the obstetrics, we can see, like I mentioned, the previous Sapporo criteria for A and C, where we use 10 weeks. In this case, 3 or more consecutive pre-fetal deaths or early deaths before 10 weeks would only give you 1 point, as well as unexplained fetal death in the absence of preeclampsia or placental insufficiency also only gives you 1 point. And they've given higher points to patients who have severe preeclampsia and placental insufficiency. And then onto our laboratory components, we can see here, similarly, they've got the 3 antibodies we are testing for, lupus anticoagulant, and our anticardiolipin and anti-beta 2 glycoproteins over here. And sorry, I see it's covered a bit here, but this first line states IgM. So you can see here they've only given 1 point to an IgM result. And then what's unique here is they've divided up into moderate and high. And this is based on a value of more than 40 as moderate and greater than 80 as being high. Okay, so coming back to our case, if we have a look at this patient, so we say she's a 42-year-old female, with hypertension, and she's a smoker, and she's got a DVT. So firstly, we've got this patient does have a thrombotic event. These are potentially risk factors. If you look at the new ACR-EULA criteria, these are, however, arterial risk factors. and she's got a venous thromboembolism. And then if we look at these anticardiolipin antibody results, we can see here that, okay, we need persistence 12 weeks apart. And in this case, this value is 31, even though it's reported as positive, and then positive again here of 47. So even though this time period is longer than 12 weeks, she actually does not meet the criteria based on the laboratory component, as she lacks a persistent antiphospholipid antibody. And this is reported positive due to the manufacturer's references that have been used. So just important to note as how one would have actually read these results, seeing it without looking at the finer detail of the criteria. After looking at case 1, we identified some other cases within our laboratory, and we saw, let's say these three are 3 separate patients. And I'll start with case 2. We can see this patient had the same hospital number with multiple different episodes. And she was tested over the years from 2019 to 2022, and these are the ages that she was at that time. And what we can see here, as I mentioned, we only do IgG testing, and we can see here, we can see of the 3 antibodies that need to be tested, this patient had all 3 tested only on 1 episode over here. She had persistence with regards to anti-beta-2 glycoprotein, as well as lupus anticoagulant, and yet towards the end of anti-cardiolipin. On to case 3, this patient had a negative result for anticardiolipin, but was repeatedly tested after that. She displayed persistence of her lack over here, but again, we can see only on her last episode was she actually tested for all 3 antibodies together. If we have a look at this last patient, case 4, we can see that this patient, despite never having a positive result, was repeatedly tested, and mostly for anticardiolipin IgG. And the findings of this study were quite interesting. These findings of the testing practices were interesting to our laboratory, and this has led us to a study, which is my master's topic, which after some modification after the marking, we've called it the antiphospholipid testing in a South African population, with Dr. Nell and Prof. Chapanduka as my supervisors. So I'm just going to tell you about my study and our findings. And what we did is we looked at samples who had testing for antiphospholipid at NHLS Tygerberg during the time period of January 2020 to December 2022. And this was a total of 8,292 samples. These were samples received from Eastern Cape, Northern Cape, and Western Cape. And we decided to stick to the Western Cape samples as these patients had unique hospital numbers and they needed to be followed up to see if a repeat test was performed. This gave us a total of 3,497 patients. If we look at this flow diagram of what we then did, we looked at the demographics of all those patients tested. We then looked if those patients actually had a positive antiphospholipid antibody. If they had a positive result, were they repeated after 12 weeks to demonstrate persistence? If they were positive again, they had 2 results which were positive 12 weeks apart and hence met the laboratory criteria. We then went on to describe their profiles if they had all 3 tests performed together. For those patients who met the laboratory criteria, we went on to assess whether they had the clinical component. So we looked at their notes and clinical records to see if there was evidence of a thrombosis or pregnancy morbidity according to the criteria. And we looked on platforms such as PACS to see if there was actual reports of radiological images reporting thrombosis. And then of those patients who met the SAPARA criteria on lab and clinical components, during the study, the ACR-EULAR criteria came out. So we then reassessed those patients based on the ACR-EULAR criteria. And of all these patients, we went on to look at the testing practices in the workup for antiphospholipid syndrome. If we look at the demographics of all the tested patients, we can see, I'm sorry, I don't know what happened. Some of the data seems to have disappeared here. But majority of our patients tested here in the yellow were female. And the group tested the most was age group 21 to 40. If we look at our antiphospholipid specific antibodies that were tested, we can see over here, of the 3 antibody tests, that anticardiolipin stands out far above the other 2. This table on the right shows the positivity. So lupus anticoagulant, despite not being tested the most, was most likely to be positive and was most likely to go on to persist, with 2 positive results 12 weeks apart. If we looked at our profiles, now, if you recall, I mentioned that it's important to test for all 3 antibodies on one episode so that we are able to assess a profile. But we saw that only 33.3%, so say a third of our patients, had testing for all 3 antiphospholipid antibodies, whether on one sample or across multiple. And even less, only 24.6% of the patients had testing for all 3 antiphospholipid antibodies together on one episode. So this did limit our numbers, as we were only able to assess the profiles of, let's say, 1,000 patients. And of this, we saw that most patients had single positive results and were single again on follow-up. And there were very few with double positive and triple positive profiles. Okay, if we look at those 3,497 patients, and we looked at those who actually had a positive antiphospholipid antibody, we then looked at 5.4% of them actually displayed persistence, which is 2 positive lab results 12 weeks apart. And then in those who had clinical criteria, we ended up with only having 1.6% of all those who were tested to actually meet the antiphospholipid syndrome diagnosis. And this was a total of 57 patients. Most of these patients were females with an average age of 33. And this was in keeping with international studies, which says that APS patients are normally females within their 3rd decade. And we can see that they had a combination of thrombotic and pregnancy morbidity as their clinical criteria. For those 57 patients, we looked at their profiles, and we saw that majority of them, again, were single positive profiles, and very few had double and triple positive profiles. And we tried to see if there was a correlation between the profiles and thrombosis and pregnancy morbidity. And we showed an association with thrombosis if you had a triple or double positive profile. However, our confidence interval here was quite wide because there were so few numbers that we actually also had to group them together, the double and triple positive profile. But there was an association. And then in our study, we failed to show any association with LAC, a positive LAC, and thrombosis and pregnancy morbidity. Okay, the next element we looked at in the study was with regards to our testing practices. So as I mentioned in the workup, we saw how patients were being tested, and we tried to group them together. So we saw there were a lot of patients who had a positive result, and then of these patients with a positive result, almost 60% of them were not repeated. Now, this is quite a large number, and we speculated some reasons why this is potentially happening. So we thought maybe these patients were lost to follow-up and they were just never repeated. The other reason, we thought maybe repeat testing was compromised. So this was maybe a patient that was pregnant, and we knew that repeat testing was not ideal during that time period. And the other option was in SLE diagnostic testing. However, we know that if you have a positive result, SLE and antiphospholipid syndrome go hand in hand. So one would still want to have a repeat positive result to then see if the patient meets the antiphospholipid syndrome diagnosis. And then the other one is potentially clinicians suspected it was a false positive at the time of testing. The other group we saw here were patients who had positive results who then were repeated too soon. And this seems unnecessary. It feels like with limited resources, repeating too soon might pick up transient antiphospholipid antibodies, which we saw, where we saw lack this is quite the case where they were repeated before the 12 weeks were passed. The test was then repeated. This is another group here. We saw patients had positive results, and then when they repeated, they became negative. And these 2 points highlight this transient antiphospholipid antibodies and the need that we need this 12-week period between a positive result and a positive result to ensure persistence. Now, as I said, some of these tests, which may seem unnecessary as they are too soon, is concerning in a resource-limited setting, such as South Africa. However, there was a Denmark study which showed quite similar findings, where only 51% of their positive results were repeated, and 50% of the patients being retested were within the 12 weeks, so also too soon. And then 43% of their patients had a full profile. So again, not everybody tested all 3 antiphospholipid antibodies together. So these practices are not unique to South Africa. And sorry, this I should have mentioned earlier, but in workup for our SLE, we noted that these antiphospholipid antibodies have equal weight over here. So where we saw in that other graph where anticardiolipin antibody stood out among the other 2, they have equal weights. So in the workup for SLE, as they give you 2 points to get a total of 10 points, it still wasn't clear why the anticardiolipin antibodies were being tested more than the other 2. The next group of patients are those with negative results who were then repeated. And we saw that 16.3% of the patients who had a negative result were repeated. And this doesn't seem like a lot, but if you look at it, it's 1,713 episodes. And this might seem unnecessary, having a negative result and then repeating it. And we wondered why was this potentially the case? So we thought maybe the patient had some the physician had some clinical concern, and that's the reason why it was repeated. How often should it be repeated is not clear. The next thing we thought, maybe it was testing in an acute setting. We know in, for example, pregnancy as well as thrombosis, due to the elevated factor VIII levels, and in this case, you've got your anti-beta-2 glycoprotein can actually bind at the site of thrombosis, and as a result, you can get a false negative. And then in the other case, we thought potentially these are seronegative antiphospholipid patients. So they've got antibodies that are not part of the criteria. However, they are still presenting like patients with antiphospholipid syndrome. And then lastly, we thought screening in SLE. So constantly looking for antiphospholipid syndrome in patients with SLE. However, this is also not clear how often, unless the patient has some clinical manifestation that makes you think of antiphospholipid syndrome. So negative results were repeated, potentially might seem unnecessary. However, we saw that 44.7% of the patients who had a negative result that were repeated then became positive. And this could then potentially say it was reasonable to repeat it, and is it necessary then to repeat negatives? As I mentioned, we looked at the patients based on the revised SAPARA criteria and the 2023 ACR EULA criteria. And we can see, based on what's stated in the ACR EULA new criteria, that the 2006 revised SAPARA criteria is more sensitive, and this is more specific. It's mainly designed to identify a homogeneous population that is to be used for research. And we saw this despite only analyzing our SAPARA patients who met our 57 patients. We looked at them and we compared them to the ACR EULA criteria. We saw that it was definitely stricter, as many of the patients didn't meet the ACR EULA criteria based on the fact that they had additional risk factors, which then gave them lower points. The strict pregnancy criteria, which would have initially made the SAPARA criteria, didn't meet the ACR EULA criteria. Or they had other causes of thrombosis, which is very clear in the ACR EULA criteria. They should not be included in the antiphospholipid syndrome diagnosis. And then the duration, which changed from 5 years to 3 years between the clinical and the laboratory component. And then drawing towards the end, the last thing we just want to touch on is our solid phase assays. And with the ACR EULA criteria, they introduced this grading of moderate, greater than 40, and high, greater than 80. And they abandoned the 99% cutoff. However, in the 2025 ISTH guidelines, they advise a 99% percentile of a local normal population. So this would require us taking 120 healthy volunteers and working out what is the 99th percentile, and then using that as the value. So this is something that we've now considered in our laboratory, as that's what has been advised. And the last element is with regards to our antibody isotypes. So as I mentioned in the ACR EULA criteria, they gave really low points to IgM. So one can think, should we just be testing for IgG if IgM on its own, which is 1 point, can't meet the laboratory criteria in any way? And after thinking about this and reading up a bit, we saw that IgM has a specific role, specifically in obstetric antiphospholipid syndrome, where it's shown to be an independent risk factor. It plays less of a role in the thrombotic component of antiphospholipid syndrome, but definitely is important in obstetric antiphospholipid syndrome. And then other isotopes like IgA, which have been noted but are not yet included in the criteria. Now, the limitations to the study. So firstly, it was a retrospective study. And as I mentioned, the ACR-ULA criteria is really, has got a lot of detail. And this proved to be quite difficult in a retrospective nature, as we needed to know about all the risk factors. And those risk factors even include things like the value of your blood pressure, as well as we need to know the gestation of delivery and the severity of your preeclampsia. And then as well as incomplete data. A lot of our request form didn't have the reason or the clinical information behind why the certain tests were being done. And we were missing some of our maternity white books where we felt like some of these factors could have been included in. And then thirdly is our profile assessment. We said that only a third of our patients actually had all three antibodies tested together. So there were a lot who we couldn't do profile assessment on. And then despite so many patients being screened, we ended up with having really small numbers. And we know this is potentially a rare disease, but this did affect our odds ratio and some of our statistics. So how do we improve the future? So firstly, we thought about within our laboratory, and this might be specific to our lab, we need to potentially create our 99 percentile in our local populations. Although it might seem strenuous to be able to get 120 normal volunteers, this is what the guidelines recommend. And then secondly, we thought about this idea, because we need to describe our profiles, potentially we should be automating it, that if you request the one, we do the other two. However, as I mentioned, you need a citrate tube as well as a yellow top serum separating tube. And that might then be an issue. If what happens if you only send one tube, what will we then do? Reject it? So these are things that we need to think about, but something that we could potentially do in the future. The next element was looking at, with regards to our resource allocation, gatekeeping tests that performed less than 12 weeks. But as we saw, a lot of the negatives became positives. So this would then also hinder the repeat negative results. And then fourthly, going on to better interpretive comments. So the latest guidelines actually advise that the three antibodies should be interpreted together. And from a laboratory side, we should be actually interpreting them together and advising on when to repeat them and so on. So this is definitely something we could improve on in our laboratory. And then lastly, potential educational interventions to the clinicians who are actually requesting the antiphospholipid antibodies, and ensuring that they're up to date with the details, as well as how to interpret the exact results that are being given by the laboratory they are using. So in conclusion, this study highlighted the complexity of antiphospholipid syndrome. And I feel like the more I read, I feel like the less I know about antiphospholipid syndrome, because it's really complex. But it is a developing field, and we really need more studies, specifically those in the screening and workup of patients towards antiphospholipid syndrome. There's a lot of studies looking at patients who are known with antiphospholipid syndrome and their profiles going on, but not so much in the screening. And we said there's really two important components to this disease. So we need laboratory and clinician buy-in. And the whole point of this would be the aim for the future. And that's to identify our antiphospholipid syndrome patients earlier, that we use our resources and we distribute them appropriately. And that will result in the overall improvement of the care of the patients with antiphospholipid syndrome in the South African setting. Thank you.
Thank you very much, Jackie. I think we could go straight into the next presentation and then handle questions at the same time, unless a member of the audience has got a question to ask, in which case I'm giving half a minute. Please, can you unmute and speak? Burning questions, just unmute, introduce yourself and speak. Good. Look, it appears like we don't have anyone. So we shall go on to the next presentation, which is by Dr. Erica Nell. And I've already introduced Erica. Erica, if you're ready, please share your slides and get straight into it. There we go.
Hey, Prof, can you see my notes, or are you just seeing my presentation without notes?
I can see your presentation, and regarding the notes, no.
Perfect, thank you.
Go for it.
I'm going to speak a little bit about lupus anticoagulant test order. Right, so let's quickly get our pointer. Okay, so when we're testing for a lupus anticoagulant, we are testing for the inhibitory process of an antibody that's interfering with clotting. So it's not looking for a specific antibody like an anti-beta-2 cardiolipin or anti-beta-2 glycoprotein 1 or an anti-cardiolipin antibody like you would test for specifically with an ELISA. It is any antibody that can bind to a phospholipid surface. So we're looking for the effect of an antibody rather than a specific antibody. And we do that using two tests, the dilute Russell Viper venom test and the lupus-sensitive APTT. And these are the two tests that are advised in most of the guidelines. And the reason that we're going to always test two is because as we are looking for an effect of an antibody, no one test will pick up all lupus anticoagulant effects. And by performing two tests, we're increasing the sensitivity of the test. So I'm going to focus on dilute Russell Viper venom test for simplicity, but two tests are definitely required, and at Tygerberg we definitely do the two tests. So when we talk about Russell Viper venom, that is the venom extracted from a Russell Viper, which is found in Asia. And it directly activates factor 10 to factor 10A, which is part of the common pathway from both the extrinsic and the intrinsic pathway. And then it's required for formation of this prothrombinase complex together with factor 2 and factor 5A for generation of thrombin. And this takes place on a phospholipid surface. So we can't get a prothrombinase complex if there's no phospholipid surface. And this all takes place in the presence of calcium. Okay, so if we have an antiphospholipid antibody, then it would bind to the phospholipid surface and we cannot form this prothrombinase complex. So for the laboratory investigation of lupus anticoagulants at Tygerberg Hospital, we follow this South African guideline for LAC testing, and you will recognize many of the names that were involved in the in generating this guideline. And in general broad overview, there are the two tests, the lupus-sensitive APTT and the DREBT. And before we start testing, we always make sure that the patient isn't on anticoagulation because these can interfere with the results. So we don't perform LAC testing if the INR is greater than 1.5 to make sure that the patient doesn't have warfarin on board. And we also perform a thrombin time on all prolonged screens so that we can make sure that it's not prolonged due to heparin. So in general, the steps involved are that we start with a DRVBT screen, which has a low phospholipid content. If that's prolonged, we go on to do a confirm using a high phospholipid content reagent. If that is still prolonged, we go on to do a mix using the low phospholipid screen reagent. And then if that's prolonged, we go on to do a confirm using the high phospholipid reagent. But I'm going to go into more detail about that now. So just hold on a little bit. Let us first understand what are the properties of a lupus anticoagulant. So they will cause prolongation of a low phospholipid clotting test. We need to be able to demonstrate that there is an inhibitor by a mixing study, and we need to be able to demonstrate phospholipid dependence of the inhibitor. And this is according to the guidelines by the British and by ISTH and by the CLSI guidelines. Okay, so in a screen, we're taking the patient's plasma, we're adding the Russell Viper venom and calcium, and the reagent has got a low phospholipid content. So these phospholipids here are these little lollipops that are all in a circle. And then for our confirm reagent, we again have the patient's plasma with the Russell Viper venom and the calcium, but now the phospholipid content is high. And the reason we want to do that is to demonstrate phospholipid dependence of the clotting time. And then the last one that's shown here is the mix using the screen reagent. So we're taking 50% normal pool plasma and 50% patient plasma, and we've got the screen reagent with the low phospholipid content. So in my super simplified diagram over here, patients that have at least 2 prothrombinase complexes forming on a phospholipid membrane surface will result in a normal clotting time. But both factor deficiency and antiphospholipid antibodies will prolong the clotting time. So in factor deficiency, it's because you don't have enough factor to form prothrombinase complexes on the phospholipid surface. And in antiphospholipid antibodies, those antibodies are preventing binding of the clotting factors onto the phospholipid surface. So let's see what happens when we do a mix. So when we do a mix, we're adding in normal pool plasma. So if there's a factor deficiency, this allows for at least 2 prothrombinase complexes to form on the phospholipid surfaces, and therefore the clotting time will normalize. However, if you have an antiphospholipid antibody, these antibodies are still coating the phospholipid surface, so adding in extra factor did not help our cause whatsoever, and the test remains prolonged. In the confirm, there is excess or high phospholipid content. So if there's a factor deficiency, that's not going to help. We still don't have enough factor to form prothrombinase complexes. But if the patient has antiphospholipid antibodies, there's now more phospholipid surfaces available for prothrombinase complexes to form, and it normalizes the clotting time. So there are scenarios where it can become a little bit more complex, and therefore we will have to go on to a mixing study using the confirm reagent. And these are the 2 scenarios where it might be necessary. Let's take a patient that has a factor deficiency and a phospholipid antibody. So the screen will be prolonged because the antibodies are coating the phospholipid surfaces. And when we do a confirm, it remains prolonged because while there's enough phospholipid surfaces now, there is not enough factor to form prothrombinase complexes. If we do the mixing study using the low phospholipid screen reagent, again, we've got the antibodies that are coating the phospholipid surface, so it remains prolonged. But then when we do the confirm reagent using the mix with a normal pool plasma, then we're adding back enough factor, and we can demonstrate that there was phospholipid dependency in the correction of the clotting times between the mixed screen and the mixed confirm. Okay. The other scenario is the high titer antiphospholipid antibodies. So here we've got excess phospholipids that are just floating around in the plasma. They're not even bound to the phospholipid surface, and the screen is prolonged. When we do the confirm, those excess phospholipids that were floating around are now binding to our high phospholipid content reagent, and still we don't have sufficient prothrombinase complexes that can form on the phospholipid membrane surface. When we mix using the screen reagent, so now there's another thing that we should understand. So because there is 50% patient plasma and 50% normal pool plasma, there is a mild dilution effect that is occurring with the antibodies inside the patient's plasma. So if we had loads of excess, now we just have a little bit of excess. And this is important so that when we do the mixing using the confirm reagent, there is now sufficient space for prothrombinase complexes to form because the amount of antibody has been reduced by the mixing study. And so you're able to demonstrate phospholipid dependence between the screen mix and the screen confirm. So when we report it, we use this beautiful table instead of the pictures that I've just shown. And you'll see a whole lot of ratios here. So we don't express absolute clotting times for prolonged or corrected, but rather it's expressed as a normalized, expressed as a ratio between the patient sample and the normal pool. And this is to reduce reagent and operator-dependent variability. So we would say it's prolonged if the ratio is greater or equal to 1.2. So if the screen is not prolonged, so if the screen is normal, less than 1.2, then a lupus anticoagulant is not detected. But if it is prolonged, then we will go on to do the confirm using the high phospholipid reagent. And if that corrects, i.e. the ratio is less than 1.2, what we will do next is do a normalized ratio. So why do we do a normalized ratio? A normalized ratio is a screen ratio over the confirm ratio. So whatever I got over here on the screen ratio, I will divide by the confirm ratio. And the reason that's important is because if my screen ratio was 1.23 and it corrected to 1.16, there isn't a big difference between those two numbers. So if I divide the one by the other, the normalized ratio will be less than 1.2. And that isn't sufficient to demonstrate phospholipid-dependent correction of the clotting times. So in that case, a lupus anticoagulant is not detected. But if there was a bigger discrepancy between the screen and the confirm, then the normalized ratio will be greater than 1.2, and then we can happily say a lupus anticoagulant is detected. So this is what we use to do lac testing at Tygerberg Hospital. And if you look at the literature about lupus anticoagulant testing, you will see that there's this nice article which calls it the good, the bad, and the ugly of lupus anticoagulant detection, where the good is basically that there is some help and there is the guidelines out there, and there is harmonization towards the guidelines, say, giving the same advice. The bad is basically everything to do with methodology and reporting and different cutoffs that are used. The ugly is the interference from anticoagulants and lack of clinical understanding, so not testing in the correct clinical contexts. And so it's really important for us to understand that lac testing is prone to false positives and false negatives. So we know that false negatives and false positives can occur in the acute phase due to increased factor VIII and CRP. And anticoagulants can also cause false positives and false negatives. And what I'm going to concentrate on now is that the way that lac testing is interpreted may also affect false positive and negative rates. So in the year 2020, the year that we got our lupus anticoagulant guideline in South Africa, where I will remind you, we have this very nice stepwise approach of screen and then confirm, and then mix using screen reagent and mix using confirm reagent. In that same year, the ICH also released their guidelines where they said that if we have a screen that is prolonged, then a confirm and a mix has to be done at the same time. And then if it is prolonged, we go on to do a mix. So I was wondering if a confirm is correcting, so that is demonstration of phospholipid dependence, but also a mix is correcting, suggesting a factor deficiency, how would I then go on to interpreting this? And has adding this mix in simultaneously assisted in the interpretation of the lac? And am I unnecessarily worried about this? Is this very applicable to lots of samples, or is this like the rare situation where both correct? So I had a look at the samples here at Tygerberg, and we looked at it over an 8-month period where 607 patients had lac testing. And if we evaluated it using the algorithm that we normally use of screen, then confirm, then mix, then 38.4% of the samples we would have reported as lupus anticoagulant was detected. 20 of those samples were detected by demonstrating phospholipid dependence on mixing. But if we used the new ICH 2020 guidelines and did the confirm and mix at the same time, then only 14% would be reported as lupus anticoagulant detected. And those same 20 samples were detected on screen and mix, mix, screen and confirm testing. And that left 148 patients, so almost a quarter of our patients that corrected with high phospholipid content and also corrected with a high mixing study. So how should this be interpreted? Should it be reported as indeterminate? Would this help the clinician, or would it hinder diagnosis? So I had a look at other centers on how they were interpreting these guidelines. So there was a publication where and 97 patients that had a positive lac screen were then assessed for the different algorithms and how to report it. And if they looked at just screen and confirm, then 91.8% would be lupus anticoagulant positive. But if they did the mix and the confirm together, then only 34% of them would be positive. And so they used the very strict criteria that they would report the lac as detected if the confirm corrects and the mix remains prolonged, as we would expect. And then they went on to say in their discussion that several patients with the clinical context that was consistent with antiphospholipid syndrome were classified as lac negative. So I'm reading between the lines there, but I think what the authors were trying to say was they were concerned that this is missing lupus anticoagulant, so it was resulting in false negatives. Another study here looked at 311 patients that were classified as lac positive, and then they reevaluated them looking at different algorithms. So if they used screen and confirm, 70.4% were positive. If they used screen, then mix, then confirm, then 34% were positive. And if they used the mix and confirm together, then they were again getting the same amount as just a screen and confirm. But they said that 111 were mixed negative. And then they went to go look for other abnormalities that might explain it, and they couldn't find any. So they ended up just calling them positive for lupus anticoagulant anyway. And this was very similar to this, this other article with a large cohort of 1,801 patients. So this publication is very complex and very detailed, and I only extracted very little information that was relevant for this talk, but it's honestly, it's a very thorough publication that you can go look at. And they, again, if they did screen, confirm, mix, 10% were positive. If they do screen, mix, confirm, then the number drops down. But if they do screen and mix, confirm at the same time, again, we're getting the same number as if we had done the screen and then the confirm. Again, they had 16 that were mixed negative, explaining the difference between these two numbers, and they were not able to find any other abnormalities that could explain that mixed negativity. And so both of these studies are suggesting that perhaps when the mix is negative, that there might be a weak lupus anticoagulant that is present, and that it was a false negative. So let me explain to you how that could occur. So this is the perfect situation of antiphospholipid antibodies that corrects we're using the confirm, the high phospholipid content, and it remains prolonged with a mixing test because there's sufficient antibodies that are still able to coat the phospholipids. But if we have a weak antiphospholipid antibody, so I've drawn it weak numerically here, so there's just fewer of them, but it could also be that they bind less strongly to the phospholipid surface, so it's not necessarily like a titer, like an ELISA. Then what happens when we do a confirm is that it very rightly, as we expect, it will correct because there can be two prothrombinase complexes that are able to bind to the phospholipid surface. But when we do a mix, we're doing the 50-50 mix. So we've diluted the amount of antibody. So it's gone down from 4 antibodies to 2 antibodies. And this means now that there is sufficient space for prothrombinase complexes to form on the phospholipid surfaces. So technically it is corrected with a mix, but this isn't because there was a factor deficiency in the beginning. This is because the mix has diluted out the effect of the weak anticoagulant, and therefore this would be a false negative. So does the ISTH 2020 guide us with any interpretation? So how we should interpret this situation? And I think it's important to realize that a weak lupus anticoagulant does not mean that the patient is less likely to develop thrombosis than a patient with a strong lupus anticoagulant. Because when because what you're measuring is an anticoagulant effect, but that doesn't correlate to the physiological part that causes the thrombosis. We're not measuring thrombotic potential. We're measuring anticoagulant effect. So all lupus anticoagulants, whether weak or strong, those are all associated with risk for thrombosis. Okay, so if we the ICH 2020 guidelines say that if we omit the mixing step, this can result in false positives and also false negatives. Sorry, I see I wrote a typo there. False positive and false negative results. So if we have a screen and a confirm that are both correcting, then they're advised that what we do is we exclude anticoagulants guidelines where we check the INR and fully it's not what's the word, covering all of the anticoagulants, but at least we're doing a good job at trying to find them. And then after that, they say we should measure coagulation factor levels. They don't go on to say which coagulation factors we must measure. So if it's a GRBBT, should we then be measuring 2, 5, and 10? And if it's a prolonged APTT, should we be measuring all of the intrinsic and common pathway factor levels? But even if we consider doing that, they go on to then say, if the coagulation factors are normal, it is recommended to comment on the lupus anticoagulant result, repeat lupus anticoagulant testing, and interpret lupus anticoagulant results along with anticardiolipin and anti-beta-2 glycoprotein 1 results to inform the final conclusion on the allay result. And that is very weird for me, because if my anticardiolipin and beta-2 glycoprotein are positive, should I sign out the lupus as positive? And if they're negative, should I sign out the lupus as negative? And so it's incredibly vague for me. So we're increasing the cost of testing, but it's still leaving me with a very vague interpretation. So in conclusion, I think what my study and what the other studies from the international studies have all shown is that performing a confirm and mix on all prolonged screen tests is not necessary, because we take reasonable measures to
Oh dear, Erica just froze there. Erica. Erica, you're frozen from my side. Is everybody hearing Erica out there?
No, it's frozen from my side as well, Prof.
No, I
Right.
can't.
All right, let me just stick my head in the office and ask her to do the last bit again.
I'll quickly go to Prof.
Okay, do that. Thanks, Jackie. Are you close, but?
Yes.
Go. Thanks, Jackie. Erica, we lost you for the last maybe 2 minutes. Do you just want to summarize your?
I think you muted, Erica.
Was I on the conclusion slide?
No, yeah, I think so, but you froze.
Okay, I will just go through my conclusions again.
Please.
I just want to check, am I sharing? No, I'm not. Let's try.
Yes, ma'am. You're on the first slide.
Okay, good.
That's right. Let's go.
Okay. So based on the findings of our in-house testing and the international studies, I've decided that performing confirm and mix on all prolonged screens is not necessary. We take reasonable measures to exclude interference by warfarin and heparin, and there are unnecessary increased costs to doing a mixing test on every single prolonged screen. And it also takes a lot of time. Our technologist performs the mixing step by hand. It's not automated in our laboratory. And even if we did it, the interpretation, according to the ICH 2020, remains really vague. So we're going to err on the side of picking up the weak lupus anticoagulants and reducing false negatives by keeping the testing order screen, confirm, and then mix. And of course, this does mean that there is the possibility of false positive lacks that could be reported, but there is the 12-week persistence that must be demonstrated and the clinical criteria that must be met. So there are other measures to reduce the overall false positive antiphospholipid syndrome diagnosis. And so we're going to continue reporting as per the South African guideline. And thank you for listening. My references were on the slide, and I will gladly take any questions. Thank you.
Right.
Prof, because I'm kicked out, I will not have access to the questions that came up before this, so you're going to have to read them out to us.
Yeah, thanks, Erica, and thanks to Jackie before you. Very nice. Even I followed, which means it was simple. Now, may I then ask, first of all, Jenny Vaughan, you have your hand up, but for the rest of us, may I please ask that you unmute and ask your question just after Jackie. I'll just do some housekeeping if there are two people at the same time. So Jenny, can you go ahead, please?
Yes, sure. Thank you, Z, and thank you, Erica and Jackie. Excellent talks. I just wanted to mention that we did a very similar study to yours, Erica, at Baragwanath Hospital, and we came up with exactly the same conclusion. The only difference is that we also looked at the antibody results in those patients who had discordant results, and a considerable number of them had a positive antibody result, which I think supports our conclusion that it's not safe to report those all as negative. And just another point from the Johannesburg perspective, in HLS, we've had a lot of problems in recent years with the antibody testing. It's become a bit unreliable. So if we do report those indeterminate ones or those discordant ones as negative, the patients can end up with no actual results to indicate the presence of antiphospholipid syndrome because they have no antibody result. So I do think it is safe to report them as positive.
Thank you so much,
On...
Jenny.
Yes, go ahead.
It's actually really nice to hear that that someone else was also worried about this, and we're coming up with the same conclusion. I think together with the findings of Jackie's study and that often it is the lack that is isolated, is single positive. It would be very difficult to use the anticardiolipin anti-beta-2 glycoprotein 1 result to inform a lack result. And I agree with you that we just can't miss all of those weak lacks. Thank you for your comment, Jenny.
Thanks, Erica. I see Dr. Nyasha Chigariro has got some questions here. Dr. Chigariro, do you want to unmute and ask your questions, or Erica, can you see the question in the chat?
Thank you. I could probably just ask the question directly.
Okay.
Thank you.
Yes. So some authors. By the way, thank you very much for the presentation. Wonderful presentation and quite insightful. So some authors do report that the classification criteria is not necessarily the same as the diagnostic criteria. So I just wanted to find out what's your comment there. And secondly, is there a role for non-criteria antiphospholipid antibodies for making a diagnosis of antiphospholipid syndrome? Thank you.
Erica?
I think this is a good Jackie. Jackie, do you want to talk about the criteria, the diagnostic criteria?
Okay, thank you for the question. I think it's really clearly stated with the new 2023 ACR UDA criteria that this is more for research based, and that one could potentially in day-to-day setting miss antiphospholipid syndrome patients, because it's really specific, and I think it's to get this homogeneous population to be able to compare and so on. So they also don't advise to use it as part of the diagnostic criteria for every day-to-day use. And then secondly, with regard to the non-criteria antiphospholipid antibodies, although there have been some findings where they've shown some association, yeah, none of even the newest guidelines say that they're not yet going to include it into the antiphospholipid syndrome diagnosis. So, and they do, everyone mentions them, but they're not included into the criteria yet.
Right. Dr. Chigariro, if you are not satisfied, please ask again. There is a question from Dr. Fatma Faisal. Have you seen it? Erica?
So,
Jackie?
oh gosh, I see the
The
comments. Let me
NHLS
see if
request
I can-
form as ACLAB as a tick option and not anti-B2GP. So might be easier for clinicians to remember and request. I think this is more of a comment than a question, isn't it? And I see someone appreciated it. All
Yes,
right.
thanks, Dr. Hazel. That's good to note. And yeah, it's something that we can also consider is does one just write on the form, antiphospholipid antibody tests. As long as you send the correct tubes, then one would do all three of them. But that's something that's good to know from a clinician's point of view. Thank you.
Right. And there is a comment by Dr. Moses Chatambudza. Have you seen it? Interesting talk, Erica. I suggest you write to ISTH with this findings so that they may consider reviewing the algorithm. Okay, there you go, Erica. Any comment on
Thank you. Maybe
Moses' comment?
we'll speak to Jenny also, and then we can combine our results.
Okay, good, good.
Just a comment on that. They seem
Yes.
extremely concerned about calling a person with a factor deficiency a positive because of the implications of lifelong treatment. So they are really paranoid about calling these patients positive. I submitted our findings to an international journal, and they were just so reluctant to accept that those results were acceptable. I wonder perhaps in our setting how much infections could be playing a role. We couldn't see evidence that HIV was causing a problem, but certainly in the cases that were collected from rheumatology patients, we didn't see this discordant result. So I think this might be something that we see more in our local setting where we have high infectious burdens than they see in other parts of the world, and they just are not interested in changing their thoughts about this.
Okay.
Right. Are there any more comments, questions? Please unmute and speak, or write
Prof,
it
I
in
see
the.
a question that Jacques Malherbe has asked about why we do not do IgM antibody testing at our laboratory, and would this not lead to some missing some cases or diagnostic steps, but that can be either IgG or IgM positive. So I'm in hematology, and I'm not in immunology, and immunology department does the antibody testing. But it was something that we went to go speak to the immunology department about. And it seems like it was just inherited that way, that they only did IgG antibody testing. And so it has been going on for all of these years. The feedback that I got is that they're about to upgrade their ELISA platform, and on the new platform, they will be able to do both IgG and IgM testing. So at Tycho Hospital, we will be in the near future, hopefully, be offering both of those tests. It was just for Jacques' MA that we didn't have that data available, unfortunately, so we couldn't do her study using the IgM data.
Yes, I agree. We should get IgM done, and I think that's on the way. So that's a development to note. Thanks, Erica. It looks like you've been looking at the chart. Is there anything in the chart
Yes, I can see them.
that you'd like to address then?
Yeah, I don't know, someone might have replied and answered this, but let me just
some of
also
those are answered actually.
Why does warfarin affect testing? The requirement to stop warfarin is problematic as patients might be high risk of subtherapeutic. I seem to remember only certain LAC reagents are sensitive to warfarin interference. Yeah, absolutely. So how does it interfere with testing? So warfarin affects how the the clotting factors are carboxylated, and so we have a whole load of factors that are floating around in the bloodstream that are not completely functional because they're not carboxylated. And so how that would appear on in testing practice is it looks a bit like a factor deficiency because those factors are not functional. So they're present, but they're not functional. And so it might look as if there is a false negative or a false positive, to be honest, in how the testing is interpreted. And it is true that only certain lac reagents are sensitive to warfarin interference, but we haven't specifically tested how warfarin interferes with our reagents, and it's just not something that we are going to be interpreting unless we go and do that validation to see at what INR it does interfere. There's also other ways to get around it. There has been some articles to suggest that you can do a one-to-one mix and then test for lupus anticoagulant based on the one-to-one mix, because when you do the mix, you're adding in the missing factor so that you can just look for the antiphospholipid effect. But it's not in the newer guidelines as a preferred method. The best method, if the patient is on warfarin and you really want to test them for lupus anticoagulant, then the guidelines suggest that either they are put onto low molecular weight, a heparin, and so you can wait out the period that the warfarin is still having effect, and then do the lupus anticoagulant testing at the trough. So we'll give the low molecular weight heparin, and just before giving the next dose, the blood is drawn for lupus anticoagulant testing. And that's possibly the best way to do lac testing on a patient that is anticoagulated. Do you have any more comments about that?
Jackmal Herbe, do you want to maybe, or he's in a loud place, he said he can't hear, but let's wait. If you type something, we'll see it.
Okay.
Any more questions from the floor?
So Garrick has asked, if the tests are not done on the same day, is there a period or window which they can still be interpretable as part of a panel? So thank you for that question, Garrick. And if there was a concrete, for the purpose of a study, if there was a concrete thing to say, okay, well, everything that's tested within a month period can be interpreted as the same profile or anything like that, then we would have done it. But unfortunately, the literature says that it all has to be done in the same episode. And if we even try to make profiles about tests that were vaguely closely done together, then at what would we make the cutoff for all of those tests being performed together to make one profile? And it really became very, very difficult. We didn't show you examples of like an anticardiolipin was tested on the 1st of the month, and then the beta-2 glycoprotein one was tested on the 30th of the month, and then the lupus was tested another 6 weeks later. Like, where is the first profile? Where is the second profile? It became impossible. So for the purpose of research, we just made it a profile is if it's on the same episode. But if it is in clinical practice and you are willing to decide on the profile, then you will have to it would have to be up to your expert opinion. And you're welcome to also always chat to your friendly hematopathologist if you want any more inputs about whether you think this can be considered the same episode, but I don't have a more beautiful answer than that. Thanks, Prof. I think I've read all of the questions now.
Great. Any more questions, folks, from the floor? Comments?
Prof, there are 2 other questions I see.
Yes, there is one from Niku Latigan. It says your comment on dogs and log testing, please. Quick. Who wants to do that one?
I'm going to try. Erica can fill in.
Go for it.
that I think the whole, in summary, it's advised not to test any patient on an anticoagulant for a lupus anticoagulant. So ideally, one shouldn't be testing these patients, but the reality that these patients are thrombotic at thrombotic risk is there. One can get certain charcoal activated DOAC, can I say a neutralizer, which then one can interpret your results, and with that caveat that the patient is on a DOAC. However, I think, yeah, if can be avoided, then ideally not to test while patients on a DOAC. I'm not sure, Erica, if you'd like to add something to that.
No, that's
I think that
perfect.
sounds
Thank you.
reasonable. Erica?
Then we have a patient scenario here by Dr. Naidu. Thank you for your talk. I had a patient with thrombosis who initially tested positive for IgM anticardiolipin and repeated 12 weeks showed negative IgM cardiolipin, but a positive beta-2 glycoprotein 1. And I've now opted to repeat in 3 months. Can you comment on the results? Okay, perfect. So I think your approach to repeat it in 3 months is indeed correct. It is strange that it would chop and change between positivity of the different entities, but it is not unheard of, and it's definitely something that we saw. I will just have you also done a LAC. I will note that there have been studies done on patients that have antiphospholipid syndrome, and they looked at their profiles, and they saw that in general, a patient with antiphospholipid syndrome, in something like 90%, or it was like 87% of patients, their profile stays the same, consistent over a 5-year period. So there's almost more weight to any one of those 3 tests remaining positive and not jumping between positive and negative. But like you said, you have now a positive IgM beta-2 glycoprotein. And so we would need to demonstrate persistence of that. Having an anticardiolipin and then a beta-2 glycoprotein 1, 12 weeks apart, does not meet the criteria. We need persistence of the same antibody to demonstrate persistence. They're also IgM, so if we think about a normal immune response, something starts out as IgM, and then eventually it becomes IgG as there's the conversion, the class switching that occurs. So I'm even more hesitant with an IgM than an IgG that it could be transient. So it's definitely something that needs to be followed up.
Good. Any more questions? Let's see on the chart. Look, there is lots of compliments there. Take them with the humility you are known for. And if there are no questions, I propose we stop at this point. Are there any questions? Just unmute and speak, please, if you have a question or comment. Good. So thank you very much, everyone. And this brings us to the end of this week's deep dive. We'll see you next week when Dr. Bizarre and Dr. Hammond speak. They are based in KZN, and they'll speak on porphyria, I believe. Good. Thanks, everyone, and goodbye.
Thank you.
Thank you, everybody. Goodbye.